Recording in progress.
Good evening, viewers. Welcome to this episode 2 of webinar series Basics in Neurosciences, organized by Park Clinic and DG Neuro. DG Neuro is a digital initiative by Health and You, always together, a joint venture with New Link Company Limited, Japan. DG Neuro is a channel on YouTube, and we have more than 56 webinars listed here, 11 international speakers, 60 plus national speakers, 1,200 plus hours of views, and 11,000 plus audience. So please go to YouTube, type DG Neuro, and like and subscribe to this channel. You have host of resource of neurosurgery and neurology on this channel. I'll quickly go through our brands of Health and You. We have innovative brands to fulfill unmet medical needs. In epilepsy management, we have Brinda, Brivaracetam, 25, 50, 7500. We have Adclobaz, Clobazam. We were the first to launch 2.5 milligram strength of Clobazam in India. Adclobaz 2.5, 5, 10, mouth dissolving tablet. In headache and migraine management, we have Amnurite, Amitriptyline plus mecobalamin combination for the first time in India. Amnurite 5, 10, 25. We have Amnurite beta, Amitriptyline propranolol combination for the first time in India. Amnurite beta 520 ER, 1040 ER. We have Brentamine, first vitamin therapy for migraine in India, which contains riboflavin, magnesium 200 milligram each, and CoQ10. And recently we have launched rapid-acting norfloxacin, naproxen plus domperidone, NDRAP, 250 and 500. In neuropathy management, as I said, Amnurite P, where pregabalin is sustained form, Neurite injection imported from Japan, mecobalamin, and Neurite D for diabetic peripheral neuropathy. And in Vertigo basket, we have Basilate, beta-estine mesylate, the only brand of beta-estine mesylate in India. Basilate 6 and 12, 25% less dosage. That's about it. Now I have great privilege and pleasure to introduce Dr. Kaushik Seal, consultant neurosurgeon, associate professor and HOD of KPC Medical College, faculty of Park Neurosciences, Park Clinic, Kolkata. He is a visiting neurosurgeon in NHR, TIICS, Amri, and Woodlands Hospital, Kolkata. He is also visiting consultant and a neurologist in neonatology and neurosurgeon in SSKM Hospital, Kolkata. So over to you, Dr. Kaushik Seal, to coordinate this session. Thank you.
Good evening, everybody. On behalf of Park Clinic, I welcome you all to this second episode of our continuing series of medical education aimed mainly at the residents and also for the junior surgeons. And each day will bring you some interesting topics that are part of the curriculum but are not discussed in details during the classes or in the lectures or in the ward rounds. So we thought that we give it a go during this evening seminar after your day's work. Today we have a very interesting topic, which is the understanding of the development of the spinal cord, the basics of embryology, and what can go wrong with this. You know, when we are students, we were just taught the mainly spinal dystrophisms in bits and pieces, and we knew about melangomyelocele, dermal sinus, and other dystrophisms like split cord, without knowing that they are interrelated to each other. Is one single embryology that can explain all these malformations. And not only that, during surgery, as we keep doing these surgeries, we came to know that the knowledge of embryology gives you more and more developed, and gives you a great deal of surgical planning while tackling this kind of malformations in neonates like dystrophisms and dermal sinus. If you know the embryology, it is very easy to follow the dermal sinus or follow a spinal lipoma and take it out from the normal conus. So the knowledge of embryology is a must, and without wasting my time, I will just introduce you to our honorable speaker, Professor Sandip Chatterjee. As you know, Professor Sandip Chatterjee is Professor and HOD of Neurosurgery at Vivekananda Institute of Medical Sciences, Kolkata. He is also the consultant neurosurgeon and Joint Secretary of the Park Clinic, Kolkata, and is a convener of the DNB course, which is being conducted at the Park Clinic. He is currently the president of the Indian Society for Pediatric Neurosurgery and the honorable chairperson of the Education Committee of the International Society for Pediatric Neurosurgery. He's a prolific speaker, and his talk on embryology is one of the most coveted ones that we will hear today. Along with him, the two panelists of today, two eminent panelists of today are Dr. Ajay Sinha. Dr. Ajay Sinha is from Alderhay Children's Hospital in Liverpool in UK. He has much interest in pediatric neurosurgery, apart from his interest in craniofacial work. And Dr. Ajay Sinha is a very important person also in this education circuit worldwide. Along with Dr. Sinha, we have another panelist, Dr. N.K. Venkatramana. He is the most senior pediatric neurosurgeon is one of the most senior pediatric neurosurgeon of India, of the country, and also the chairman and director, neuroscience, chairman and director of neurosciences at Brain Hospital, Bangalore. His contribution to pediatric neurosurgery development in India is immense, and we are fortunate to have him in as our panelist. So it's over to the panelists to invite the speaker for the talk. Sir.
Good evening. Can you see my screen?
Yes.
Yes, sir. Yes, sir.
Okay.
Yes.
So,
Yes, sir.
good evening and welcome. Today, as you may or may not be aware, is World Brain Day. And therefore, I bring everybody greetings on the occasion of World Brain Day, which is what 22nd July is now designated to be. It's a day that we are supposed to all understand the significance of the brain. But unfortunately today, I am going to talk about the spinal cord. And the talk today is going to fundamentally be on development of the spinal cord, talking mainly about the basics of embryology and telling you what can go wrong. And I would like, right in the beginning, to acknowledge both for this talk and for my understanding of this subject, the man to whom I owe the most, my dear friend, Professor Michel Gérard from Neckar Hospital in Paris, France. And Michel is responsible for a lot of what I'm going to talk to you about today. And indeed, some of the visuals and the arrangements of the visuals is also contributed to by Michel. And I'd like to acknowledge him right in the beginning of this talk. The other man I would like to acknowledge is this gentleman, Professor Dakling Pang, who of course has contributed immensely to our understanding of the subject. And Dakling has been a critical reviewer of this talk and suggested modifications to it, which has been done. But this is a very rare occasion when in Calcutta I had an opportunity to entertain both Michel and Dakling on the same table and to read out to them a little bit about our concepts of embryology. So long before all this began, of course, interest in spinal cord, its anatomy and its development goes back to these four individuals, starting with Hippocrates on the top left and going clockwise right to Galen, Steno, and Celsus, the four individuals in ancient times who first exhibited an interest in trying to understand the anatomy and indeed the development of the spinal cord. But I'm going to start off with this man who hails from a village in the northern part of the state where I live in India. He's called Chandre Oram. And this is in fact a clipping from one of the newspapers in the United States, which shows Chandre Oram climbing a tree with the title, "Meet Monkey-like Man Worshipped by Indians like a God because of his tail." And Chandre Oram works in a tea garden in Alipurduar in North Bengal. And of course, He earns his living not because of his ability to climb trees or his work in the tea garden. He earns his living because of his tail. He's considered to be very special, and he spends a lot of time blessing individuals. He also claims he was born on Ram Navami Day, and indeed sometimes puts on the full Hanuman gear to bless children. And this is in fact his source of income, all attributed to this tail. And these are recent photographs from a year to a year and a half ago. From that to the tail and the development of the spine as we have understood it. If we look at the tail of the Amphioxus and we draw a cross-section of the spinal cord, it has one cell. As we move to the tunicate, it has 4 cells. These are cross-sectional anatomy of the spinal cord of these creatures, until we move to the lamprey. And the lamprey, as you can see, has a highly developed cross-section of the spinal cord with a lot of differentiation as you go from medial to lateral and as you go from dorsal to ventral. And indeed, the jawed vertebrates, which we use as a model, the mice, has a very similar architectural anatomy of the spinal cord. If you really want to see what is the state of the spinal cord development as we understand it today, well, this is what it looks like. You have these amazing molecular groups. If you look at the lateral of the spinal cord, it is controlled by somite-derived factors. If you look at the dorsoventral, it is contributed to by the ectodermal-derived TGF-beta and the notochord-derived sonic hedgehog. And therefore, this is what, in fact, a molecular biologist would see in a developing spinal cord. And this is indeed what I talked about, the dorsoventral differentiation, which is contributed to by the balance between BMP-derived factors and SHH-derived factors. And this is what decides why there is a differentiation between what happens in the dorsal part and in the ventral part of the developing spinal cord. So you might think, on one hand, we talk about a man with a tail being worshipped, even in the India of today. On the other hand, we talk about the spinal cord development being conceived upon as a number of molecular factors which contribute to dorsoventral differentiation, to craniocaudal differentiation, and a new set of molecular genetic factors that contribute to lateral differentiation of the spinal cord. And I think this represents the 2 extremes of our understanding of the development of the spinal cord. And perhaps it is time to pause and look at the great Lord Buddha and remember about his preaching of the middle path. And perhaps the rest of the talk, we should not talk about the maximum or the minimum as far as spinal cord is concerned. Let us look at the development from what is optimum. And the spinal cord develops in 3 stages. And these are the 3 stages. The first stage is called gastrulation, which means that a 3-layered embryo is formed. The second stage is all about the neural tube closure, again influenced by what changes occur on the dorsal aspect of the embryo, different from the ventral aspect of the embryo. And this neural tube becomes the tube and separates from the surface. And finally, below the neural tube is a cluster of cells called the caudal cell mass. This caudal cell mass integrates itself into the bottom of the neural tube. And this process is called secondary neurulation. So the spinal cord develops by a combination of gastrulation, neural tube formation and closure, and secondary neurulation. That's all there is to that, and this talk would well end here. But let's take a little look at gastrulation. And if you look at gastrulation, that's the formation of the primary germ cell layers. And if you remember, between the amniotic cavity and the yolk lies the embryo, which consists of two layers, an epiblast and a hypoblast. And it has a cranial end and a caudal end, and you will see at this stage no differentiation till on the dorsal aspect of the embryo, we have changes that start occurring. And of course, that's when you have formation of what's called a definitive endoderm, which means if you look at the cross section of the embryo, remember, there's an epiblast and a hypoblast, and there's the primitive streak developing, and from there, the cells come in and change, and the so-called cells of the hypoblast become the definitive endoderm. And then the most important step of gastrulation occurs, which is that some of the cells of the epiblast transform themselves into mesenchymal cells like so, and forms the mesoderm. So we now have an embryo which has three layers, an ectoderm, and mesoderm, and an endoderm. And of course, if you look at the expansion of the mesoderm, it occurs like this. And remember, I told you not only the dorsoventral differentiation, but the lateral differentiation, the lateral spread, which is now we know controlled by a variety of specific somatic factors. And then there develops this thickening called the neural tube. And of course, as we go on, this neural tube forms the notochord and the spinal cord. At what happens in a sagittal and a cross-sectional view, this is what happens. That structure that it pushes itself is the notochordal canal. Around the notochordal process, and that's the primitive pit on the dorsal aspect. This notochordal canal, as you can see, is intercalated in the embryonic endoderm. And therefore now you have a situation like this. And this is important for reasons we will come to in a minute. Again, if you look at that's the canal, the neuroenteric canal, which communicates the amniotic cavity with the yolk sac. And this neuroenteric canal gradually closes. And at the same time, the notochordal plate enfolds itself. And that's the start of formation of these folds called the neural folds. And that's what the embryo begins to look like as we end this particular stage of the video animation. So gastrulation is the first step in development of the spinal cord. And gastrulation basically means formation of a trilaminar embryonic disc. Okay. And we've already told you how the mesoderm spreads. Let's go to just understand one little thing. And that is, again, the most critical step of gastrulation is this epithelial to mesenchymal transition that occurs. And this is a beautiful article published in a very unusual journal called Cell Adhesion and Migration. And I love the title of this article. It says, an amicable separation, a chick's way of doing epithelial to mesenchymal transition. And in fact, it is the chicken that has given us the maximum information about development of the spinal cord, a fact I will come back to in a few minutes' time. Let's go to stage 2, the closure of the neural tube. And there are 2 steps in this. The first is called primary neurulation, which means you get a tube that forms on the surface. The second is called disjunction, which means that this tube now moves away from the surface. So what happens is somewhat like this. What happens is something like this. you get an infolding of the surface. So this is the tube that's formed. This is the surface. So the first step is formation of this neural tube. The second step is the separation of this neural tube. And we'll come back to this in a minute. Relation means formation of a neural tube, and then this from the surface. And this separation of cutaneous ectoderm, which is here on top from the neuroectoderm, is an embryological process called disjunction. So the second step of formation of the spinal cord, and I'll illustrate this in a minute, is primary neurulation, which means you have neural folds that elevate, join together, form a neural tube, and disjunction, which means the neural tube now separates, so the neural ectoderm moves down from the cutaneous ectoderm. And the final stage is called secondary neurulation. This means, as I said, the caudal cell mass forms a cavity and joins the bottom of the neural tube. Let's look at both the neurulation and the primary and the secondary neurulation again, going back to where we left off in the previous diagram. So here's the notocaudal process. You will recall this is what happened at the end of gastrulation. And now the neural tube starts forming. This is a 20-day embryo, and you're looking at the dorsal aspect of the embryo. And this is the formation of the neural tube in cross-section. You have the surface ectoderm up there. You have these surface ectoderm being elevated as neural folds. This is the mesoderm. And as these neural folds get elevated like hillocks, their medial aspects tilt towards each other, causing a closure. And as they close, you now have a surface ectoderm and you have a neuroectoderm, and they separate by a process called disjunction. So if you now look at a 20-day embryo and look at its dorsal aspect, the neural folds have formed. There is a neural groove. Remember the primitive streak at the bottom. And of course, in the region of the brain, which is the top part of this neural tube, the growth is so much more that the weight causes it to bend, and you gradually develop a cranial bending of the neural tube. That's the forebrain, that's the rostral neuropore, which closes, and we'll talk about this closure in a minute. That's what happens as the top end becomes more, and a 25-day-old embryo looks like this. So it's important to see how gradually, as you go to 25 days, not only does the neural tube elongate, it broadens at its top end to form the brain. And of course, it is important to remember that between the surface ectoderm and the neuroectoderm, as the neural tube closes, remember you have these cells, the cells of the neural crest, that now develop here. And you'll watch this in this video in a second. And these cells of the neural crest, like here, contribute to the dorsal and ventral neural pathway. And of course, they also contribute to the autonomic ganglia and the adrenal medulla. Secondary neurulation, you remember, that's the caudal cell mass. This caudal cell mass first develops a cavity within it. There's a lumen, and there's the joining between the caudal cell mass and the primary neural tube, producing a continuous neural tube, and that's secondary neurulation. That's the summary in brief. Okay, so just to sum up again, the embryology of the spinal cord, gastrulation, which is development of the germ cell layers, neural tube closure, which is primary neurulation, where the neural tube forms, and disjunction, where it separates from the cutaneous ectoderm, and finally secondary neurulation, where the caudal cell mass develops a lumen, joins the bottom of the lumen of the primary neural tube, and forms the terminal spinal cord. Quite simple. And therefore, very simply, this is what happens as you move from germ layer establishment to neural tube formation to separation of cutaneous of neuroectoderm, and finally the formation of the terminal part of the spinal cord. Fantastic. What goes wrong? Well, at every stage, everything can go wrong. And when they go wrong, we have exotic names for them. The problem is that the goalpost changes as we give them different names. Meningomyelocele become terminal myelocystocele. This is a condition which, when I was a trainee, would have been diagnosed by all pediatric neurosurgeons as a dorsal meningocele. Today, we know it's a limited dorsal myeloschisis. This is a condition that would have been called a meningomyelocele. Today, we know it's a terminal myelocystocele. So how the hell do you cope with all these nomenclatures? The answer is, remember embryology. Remember the basic difference between the two types of abnormal embryology that can occur: the open dystrophism and the closed dystrophism. And remember, it's the open dystrophism which is folic acid dependent. The occult is not. The problem is that we have to rely for all our information on the embryologists. And the problem with embryologists is that most of their work, as I pointed out before, is based on work done in chick embryos. So all our information of human beings, and not only from chicks, even worse, we've downgraded ourselves to the Drosophila, and finally upgraded to the mice, which is the most advanced model we've used to try and understand the development of the spinal cord. Little surprise then that I always admired this article published years ago in Child's Nervous System, which says, pathogenesis of diastomatomyelia. Can a surgical model in a chick embryo give clues about human malformation? And indeed, can anything in chick embryo give us very clear ideas about what happens in a human spinal malformation? And the answer is, we do not know. So we move from this open and occult dysraphism, which we knew about, to now trying to understand what are the problems that occur if gastrulation goes wrong. Gastrulation, remember, is formation of 3 layers. So if gastrulation goes wrong, the problems that occur are generally ventrally placed. All the germ cell layers are involved. And if all the layers, particularly mesoderm, is involved, you get skeletal anomalies. Aha. So you get conditions like this called neuroenteric cysts, which means have persistence of the neuroenteric canal, which I just showed you in one of the cartoons. But here's a very important fact about the neuroenteric canal, which goes from there to there, joining the amniotic cavity with the yolk sac. The neuroenteric canal, as it goes from cranial to caudal, moves from ventral to dorsal. It would have to, because it would have to join the ventral yolk sac to the dorsal amniotic cavity. But what does that mean in terms of abnormalities of the neuroenteric canal? It means that if you get a developmental anomaly like a neuroenteric cyst, And this is located cranially, read in the cervico-dorsal junction. Then this cyst will be located ventrally, ventral to the spinal cord. If you get a neuroenteric cyst at the caudal end, lead the dorsal lumbar junction, this cyst is likely to occur dorsal to the spinal cord. And this very basic knowledge of embryology, which is that the neuroenteric canal joins the yolk sac ventrally with the amniotic cavity dorsally, explains this anatomical fact. So, neuroenteric cysts can have endodermal elements. They can occur anywhere along the path of the neuroenteric canal, and they would generally have bony abnormalities as well. The treatment, of course, would be to remove the cyst and untether, and we won't talk about it. Just to show you, a neuroenteric cyst located ventrally. This is a lady who'd been operated 3 times in the past, who I inherited when she was completely quadriplegic, had respiratory problems, and even worse, was pregnant at the age of 20. And of course, she'd been operated from the back 3 times. Here's a neuroenteric cyst you need to get rid of. And because she'd had 3 surgeries from the back, we decided to go in from the front, remove the vertebra from the front, so that beautiful neuroenteric cyst. And because she was not a child, but an adult of 20, we removed that vertebra, fixed it like so. And of course, we could shell out the entire neuroenteric cyst, and that's her at 5-year follow-up, showing absolutely no recurrence. So a neuroenteric cyst is one of the disorders of gastrulation. The other common disorder of gastrulation is the so-called split cord malformation, which means that you have splitting of the notochord, induction of 2 neural plates, and a duplication of the spinal cord. And of course, this is possibly the first painting we have, which goes back over 300 years ago and shows a young boy with a tail like that, which must have been a manifestation of a split cord malformation. These are called type 1 or type 2, depending upon whether the dural sac is 1 or 2. And this, the famous unified theory of the genesis of split cord malformation, basically simplified, means this. If you have 2 hemineural tubes, like here, you look at the bottom left of the screen, and you have 2 notochords. Stretching between this ectoderm and this endoderm is this tract. It's called the endomesenchymal tract. This is the one that divides the 2 spinal cords and the 2 notochords. And this gradually regresses with time. Now, around these 2 neural tubes are these cells called the cells of the meninx primitiva. And from the name meninx primitiva, you can guess they form the dura or the meninges. And of course, if the endomesenchymal tract is still there, the cells of the meninx primitiva form 2 dural tubes around 2 neural tubes. If, however, the endomesenchymal tract has regressed, the cells of the meninx primitiva can go around both these neural tubes and form 1 single dural tube. When they form 2 separate dural tubes, that's called a type 1 split cord malformation. When they form 1 single dural tube around both the neural tubes, that's called a type 2 split cord malformations. Again, they will often have skeletal abnormalities for much the same reason. Here's a boy we've treated with scoliosis. You can see the septum in the split cord, which you can remove like scoliosis. This child needed fixation as well and ended up from there to there. The split cord malformations type 2 are much more difficult to both operate on and to in fact decipher, because there is no bony septum generally. There is a fibrous septum or a bit of cartilage. Okay, so the disorders of gastrulation fundamentally are 2 types: neuroenteric cysts and split cord malformations. And split cord malformations are of 2 types: type 1, if you have 2 separate dural tubes, and type 2, if you have 1 dural tube. Let's move to the problems of neural tube closure and take them in 2 parts. disorders of primary neurulation, and disorders of disjunction. The disorders of primary neurulation fundamentally mean the neural tube remains open, so there is no skin. And of course, this is the so-called myelocele, where you have, of course, the neural folds exposed to fresh air. This is folate dependent. And therefore, this is something that we have been trying to plead with governments across this planet to try and reinforce folate in the diet of pregnant ladies to prevent these sort of abnormalities. And you'll be pleased to know from the International Society of Pediatric Neurosurgery, 11 of us across 5 continents have just authored an article which has been published in this month's Child's Nervous System, and which we intend to use to plead to governments across the world to stop this abnormality by adding folic acid in the diet of pregnant ladies. Just to recall again, the neural tube folds like this. Remember, there is a groove, then there is elevation of the 2 sides of the groove. The 2 hillocks form on the 2 sides, and then gradually they join together like so. And then you have this neural tube that separates itself from the cutaneous ectoderm by a process of disjunction. Before we thought the neural tube closes from below upwards, much like the zipper. Now we know that it closes at multiple points, much like the buttons on your shirt. And indeed, you may be interested to know the very first diagram, an illustration of an open neural tube defect, is from this textbook from Nicholas Stulp. Remember the Rembrandt painting of the anatomy lesson of Dr. Nicholas Stulp? Well, Dr. Nicholas Stulp, who wasn't really a qualified doctor, wrote this fabulous book, and this was his very first spina bifida, which he labels here, showing an open neural tube defect. So, disorders of primary neurulation cause open neural tube defects, the meningomyelocele. What about disjunction? Well, there are 2 problems that can occur with disjunction. Disjunction could be incomplete, which means there is incomplete separation of the neuroectoderm from the cutaneous ectoderm, or disjunction could be premature, which means before the neural tube has closed, it separates from the cutaneous ectoderm. Let's see what happens. If you have incomplete separation, obviously you have a connection between the cutaneous ectoderm and the neuroectoderm. And the condition that you get is called a dermal sinus tract, which is, of course, a problem of incomplete disjunction. The other problem you can get is a limited dorsal myelogenous. And of course, you can get a cutaneous neuroectodermal connection whose name probably will be rediscovered in another few years. So in a dermal sinus tract, you have a lovely tract like this going from the cutaneous ectoderm there to the neuroectoderm here. And of course, this is a dermoid cyst at the bottom of that spinal cord. This is a limited dorsal myeloschisis. This is something that Professor Pang described in this article. What happens here is there is incomplete fusion of the neural tube when they start separating. So it drags a bit of this cutaneous ectoderm, and you get a stalk like this, a bridging, persistent cutaneoneuroectodermal tract. And this persistent neuroectodermal tract is nothing but a bit of cutaneous ectoderm and a bit of neuroectoderm that stretches from the surface to the neural tube. And this is called a limited dorsal myeloschisis. And sometimes, if you're lucky, you have everything thrown into one. Here's a child that we operated on some years ago, came to us with a little opening on one side of the midline, a bluish spot on the other side of the midline. So 2 spots, an opening on one side of the midline, a bluish spot on that. This opening means almost certainly that's a dermal sinus tract. This elevated bluish area means that that's likely to be a limited dorsal myeloschisis. The fact that they're not on the midline, one on each side, almost certainly means this, that there is a diastomatomyelia or a split cord malformation. And of course, you have a tract on one side, which is going down to one hemichord, which was a dermal sinus tract, a tract on the other side going down to the a spinal cord which was a limited dorsal myeloschisis. Histologically, that's what one looked like with the dermal sinus tract. This had neural tissue and was like a neuroenteric cyst. So if you have incomplete separation or incomplete disjunction, you can get either a dermal sinus tract, which is lined with squamous epithelium, or a limited dorsal myeloschisis, which will also have neural tissue because of the persistent neurocutaneal ectodermal tract. Okay. The other problem we said that could occur with disjunction was it could be premature. What happens if you have premature disjunction? So that's your cutaneous ectoderm. That's your neural tube, which is going to close and then separate out, but the neural tube decides to separate out before it's closed. And when that happens, the surrounding mesoderm, you will remember the trilaminar embryo has mesoderm. This mesoderm gets into that opening, much like an ice cream does in a cone. And you end up with an intact skin. The cutaneous ectoderm is developed. You end up with a lump, which is caused by this mesoderm, which sits on an open neural tube. So you get a neural placode, you get the dura, which ends on the sides, and you get a normal skin cover, producing the so-called lipoma. In fact, it is the dorsal type of lipoma, whose genesis is by premature disjunction. If you look at the types of lipoma, then 15% of the lipomas of the phylum. This is a problem of secondary neurulation. The lipomas of the conus, which is 85%, well, the dorsal of this variety, and this is a slide I borrowed from none other than Professor Ale Pierre-Kahn in his seminal talk on lipoma classification from Paris. And this is a dorsal lipoma. This is also from Professor Pierre-Kahn, and this is a terminal lipoma, where it's at the bottom of the spinal cord, and a transitional lipoma. The important thing to appreciate, the dorsal lipoma is caused by premature disjunction. The terminal lipoma or the transitional lipomas are caused by disorders of secondary neurulation. And of course, Professor Pang, this is from his article, finally described a new type called the chaotic, again, a problem of secondary neurulation. So when we look at a lipoma from a pediatric neurosurgical point of view, this is what we see. We see an MRI which looks like that. We see a lump clinically that looks like that. And we imagine a situation like this where C stands for intact skin, M stands for mesoderm. You get a lump which is not cystic but soft to firm, which is the lipoma itself. And N is the open neural tube at the bottom, which produces the propensity to develop a neurodeficit. So if you understand the embryology of a lipoma, you know its clinical features. The skin will be intact. There will be a soft or firm lump. And of course, there will be a propensity to develop a neurological deficit because you have an open neural tube below. So those are the abnormalities of neural tube closure. Finally, the disorders of secondary neurulation. Remember, that's when the terminal spinal cord forms, and the secondary neurulation syndromes could be the so-called caudal regression syndromes, the Currarino or triad. And remember that the secondary neurulation disorders are often associated with hindgut, urogenital, and spinal abnormalities. And of course, caudal regression is a failure of the process of secondary neurulation. And the retained medullary cord is one of the newer kids on the block, added as an example of failure of secondary neurulation, where at the bottom you have medulla inside what looks like a thick phylum terminalis. Fortunately, for neurosurgeons, this does not have functioning neural tissue. And the complex lipomas, of course, are all disorders of secondary neurulation. So, if we were to sum up all the embryological disorders that cause dysraphism are disorders of gastrulation, which is establishing the germ layers, disorders of neural tube closure, which could be either disorder of primary neurulation, which is formation of the neural tube, or disorders of disjunction, which is separation of the neural tube from the cutaneous ectoderm. And finally, could be disorders of secondary neurulation. If we now take this off and just think about the abnormalities, the entire spectrum of dysraphism falls into place in this beautiful embryological rainbow. Disorders of gastrulation cause split cord anomalies and neuroenterixis. Disorders of neural tube closure of primary neurulation produce open neural tube defects. Disorders of disjunction, where the disjunction is premature, causes a dorsal lipoma. If it's incomplete, you get dermal sinus tracts and limited dorsal myeloschisis. And disorders of secondary neurulation cause complex lipomas, myelocystocele, and caudal regression syndrome. So everything that we talk about in dysraphism falls beautifully into place in this embryological scheme of things. And of course, to this has been added recently problems caused by junctional defects, means defects that occur between the bottom of the neural tube and the top of the caudal cell mass, and the unjoined primary and secondary neural tubes produce another types of defect called the junctional neural tube defects, which for purposes of maintaining simplicity, I'm not going to go into details, but that's the article that can tell you all you want to know about it. And this is what it looks like. You can get a scenario where the cord ends at one level, and then below that, you have functioning tissue, a phylum which has suddenly become thick. Time to close. Summary. Embryology, when it goes wrong, produces the dysraphic states. These are best understood if you understand the embryology. Each can be associated with a neurological dysfunction. And this may provide a beautiful unifying scheme of these disorders. Unfortunately, all this is modeled in chicks and mice and may possibly be completely wrong as human beings are concerned. Thank you very much.
And thank you, Sandeep. Wonderful talk as usual. Any queries, any comments from others in the medium?
Sandeep, I must congratulate for a very comprehensive, concise compilation of this entire embryology to simplify, for educational purposes for the students and to understand the range of or a spectrum of the abnormalities what we encounter in the clinical practice, so that we can plan it better. As you rightly said, I think we have evolved in understanding this over the decades, extrapolating from the embryology of the various animals to, to a level of understanding where we can. And probably in future, the functional imaging of the development of the embryos might help us, and also the fetal neurosurgery, which can be based on these kind of understanding. Probably fetal neurosurgery will have a big leap forward to do this. I must congratulate for a very comprehensive understanding, and it's a very difficult topic, and you put it excellent way, and so that everybody can comprehend. And I wish Professor Pang has described reverse this type 1 and type 2 for the students to remember very easily. Type 1 with a single neural tube and type 2 with a double neural tube. I think it would probably will be better. So other than, I think for them to remember easily. And still, of course, is a very complex situation where, as you rightly said, the junctional disorders and many things are difficult to explain. And this keeps us going, still looking at the newer aspects of these spinal cord malformations.
I couldn't agree more. Sorry, go ahead. I stopped you.
No, Ajay, go on. You were going to make some comments.
No, I just wanted to just say that, things like, failure of primary neural tube and second neural tube joining up on junctional disorders, I think they are beyond the comprehension of the average neurosurgical trainee. And I would not let them get bogged down into that. If they can get the basic gastrulation disorders, neurulation disorders, and post secondary neurulation problems clear in the head, that's good enough for most exams anywhere in the world.
Yeah, I sometimes think that we have probably made dysraphism more complex than we could have made it. And my whole idea is to try and make it a little simpler than a lot of our great pundits in dysraphism have sought to make it. And I think sometimes we make things more complicated than absolutely necessary.
I totally agree with you. And this is the way to go forward. And this will help in two ways for the students to, get a comprehensive view and to remember this embryology. I'm sure no one will be able to write an answer to the satisfaction with the earlier confusions. I think that's the clarity which we need to bring in. Congratulations for doing that again. The second thing, I think now, like we clearly know that open dysraphisms are folic acid dependent, occult ones are not folic acid dependent. We also know that the genetic and SSH pathways, right? I think probably future will be to identify, even for the occult ones, what is that influencing at each of these gastrulation to each of these stages, where these abnormalities can be identified and probably prevented. I think that should be the future research. I think this has got a great relevance in my opinion. I think we need to take this into the clinical translation in terms of identifying the factors which influence these stages and what factors, absence or excess, can create these kind of defects, which in turn can cause this variety of abnormalities. I think that will be much more fascinating for the future research. I think that's the way we need to go forward.
Just one on the same theme, which Dr. Venkatraman rightly pointed out. Nowadays, here, because of high quality intraoperative antepartum MRI scans, we get a lot of antenatal counseling where patients have a small dorsal lipoma picked up in late trimester pregnancy, or a type 2 or a type 1 split malformation, and or maybe LDM, which gets picked up nowadays. They always look at the cerebellum and they'll find a tiny little LDM. And the understanding has really helped us in a long way to try and allow this pregnancy to continue. And the fetal medicine chaps would definitely talk to us, consult us before even considering, because the families get very distressed and some of them even would want late trimester termination. So we have to be very, very clear in our own understanding so that we can counsel them. And more, as this is already happening for us, I think it's going to happen across the world, that you'll be asked to counsel for a dorsal lipoma, or for which is going to have a very good prognosis. If it is simple dorsal lipoma, the prognosis is not all that bad as people try to make out. So that's something, understanding the embryology helps.
Yeah, I think someone is speaking and behind. If they can mute, if I can request them to mute, some parallel discussion is going on behind. Sandeep, can I ask you a question? Can any of these mechanisms, how do we explain this in pure intramedullary lipomas?
I think, the intramedullary lipoma, most of the intramedullary lipomas are either a dorsal or a transitional with an extension. Now, if you have a pure intramedullary lipoma, that may not be an embryologically dystrophic part of the spectrum. You could just have and we've seen intramedullary lipomas in teenagers and adults which have no dystrophism. They do not have a loconus, they do not have a tight phylum. It's like any other intramedullary tumor. I think there's a very fine line between these that are pure intramedullary tumors and those that are part of the dystrophic spectrum.
Actually, the same as
in our series of lipomas, where we serially studied the histological aspects, showed very interesting features like originally where a brief article was published by Alan Pirakan from Paris, that we have a lot of interesting issues starting from, you name it, anything, renal tissue, appendix, intestinal tissue, lymphoid tissue, cartilage, bone. It's very, very fascinating things. You think it depends we know that it is a premature disjunction. It depends on what day it happens or how do these endodermal structures and mesodermal structures get entrapped into
Just a small little addition to the discussion. I think for Indian trainees, Dr. Mahapatra published presented his paper. I'm sure he must have published it. I haven't read some of his recent works. He classified type 1 split cord malformation into A, B, C. So, if you get examiner from All Indian Institute, he might be asking you about Mahapatra's sub-classification of that. So be aware of that. Yeah, and that depends on where the actually bony spur is. If it is the very bottom or in the top or in the middle, I think he's sub-classified it. So just be aware. He is very keen on asking.
Now that becomes a purely radiological classification now. So if at all.
In fact, Ajay, you do not know, but last week I have received from Professor Mahapatra his textbook of split cord malformation.
Oh my goodness.
So it's a full textbook now that I have just been presented it 10 days ago.
Right. And I'm sure he's talked about the sub-classification in that.
Oh, yes. I just wanted to say that, this concept, this molecular genetic map is absolutely fascinating because you can now see what BMP and SHH are doing in terms of helping those hinge cells of the neural tube to bow their heads towards each other, because when these cells bow their heads towards each other, the neural tube closes. And it's quite fascinating where we know all this molecular genetics now. The problem is that that doesn't help our clinical understanding at all. And it doesn't help our management. So that's why I just showed you a little bit of the new molecular genetic map of the developing embryo. But we really have now information about almost everything that occurs and what's the gene that controls it, which is absolutely fascinating.
At the moment, they do not help in clinical management, but I have a strong hope that
it will tell basically if you have linked already some data for one patient and you want to try to link all the data, you will tell you that this patient is already linked.
We can hear what's happening in Walton.
Yeah, please, sir.
Everything.
Oh, Ajay, you are there. Okay. All right, sorry. So I was just telling that, at the moment we know the possible pathway, but tomorrow, my feeling is that tomorrow certainly we will have biomarkers which is going to influence these paths. I think then it will become very interesting to see that where we can really intervene, in transforming or prevention or possibly avoiding the complications of this whole process. At the moment, it is still in the nascent phase. Yeah.
There is a question in the chat box from Dr. Sudipto from Dhaka. Please re-explain the anatomical site of neuroenteric cyst. I think about the ventral and the dorsal part, what you have shown.
So the neuroenteric canal, as I showed you, joins the yolk sac to the amniotic cavity. The yolk sac is ventral, the amniotic cavity is dorsal. So as the cranial part of the neuroenteric canal is located ventrally, the caudal part of the neuroenteric canal is located dorsally. So if you have a sequestration of some cells of the neuroenteric canal cranially, which means at the cervico-dorsal junction or in the cervical spine, then this neuroenteric cyst has to be, by embryological reason, ventral to the spinal cord. Whereas if you have a neuroenteric cyst at the dorsal lumbar junction near the conus, because here the neuroenteric cyst is going up dorsally to go into the amniotic cavity, here, the neuroenteric cyst will be located dorsal to the spinal cord of the conus. That's the point I was trying to make.
And there's another question is, has the addition of folic acid reduced the incidence of neural defects in the last decade?
Absolutely. Hugely in countries that it has been. And as I said, if you want to read the letter to the editor that I'm co-author of, and 11 of us have written in Child's Nervous System in this month's edition, you will have the facts there. You can see the facts. A small country like Costa Rica has completely almost stopped open neural tube defects simply by fortifying their wheat with folic acid.
But do all open neural tube defects are due to folic acid deficiency?
Yes, very much so. All open neural tube defects are due to folic acid deficiency.
I couldn't agree more, and this has been evident even in most places now. Though it doesn't eliminate 100%, but it does reduce to a large extent, and it's quite evident in Northern Ireland and even in the local population here. The incidence is definitely much lower compared to what it was 20-30 years back or for 50 years back.
So folic acid fortification in wheat or rice is much more effective than even tablets that we do in India right now.
A lady decides to start taking tablets, she may have already missed a period, and the basic neurology would have already happened. So it's timing your folic acid. You have to start before even think of having children. You have to start before.
You're muted. Ajay.
Oh, sorry. I've been extra careful.
Yeah.
Now, what I was trying to tell you, emphasize is that there's no point in starting the folic acid after you missed your first period. Damage could have possibly already been done. So it has to be started much before, and that message has to go through. And it's not for us. I think it's for the gynecologists and the pediatricians who have to emphasize that more than us. And so the education has to come from their side and from the ASA workers and the healthcare workers everywhere.
It's in cities is quite well, taken up in India. I think certainly rural areas is still a problem. I think we need to address that. It should be a wedding gift rather than after the first consultation.
I think it's fantastic, the idea of making it a wedding gift. Okay, Kaushik.
So there are no other questions from the chat box, I gather.
The last question I have just entered.
Yeah. Dr. Power.
The question is in chat box.
Question is in chat box. Dr. Power, anything you are seeing? Because I am.
So, doctor, the question is: are you think arsenic is related with the open NTD? Question from Dr. Sudipto from Dhaka.
Yeah. Relationship of arsenic to the NTD.
I don't think there's any evidence that arsenic is directly an etiology of an open neural tube defect. Arsenic has a lot of neurotoxic factors, of course, and it causes a lot of neurotoxicity, but I'm not aware of any evidence linking the two.
So another question has come is whether frontal encephalocele or occipital encephalocele is a part of the embryological defect.
Yes, of course it is. It's the same thing. If you get an encephalocele, it is the same thing that's occurring just higher up in the brain vesicles. What is happening lower down when you get a neural tube defect in the spinal cord? The embryological basis is identical, just like you get a dermal sinus tract in the cranium. The basic embryology is the same.
So if there are no other questions, any parting comments from the panelists? Dr. Ajay?
Just a small, there are quite a few painters like Rembrandt and, as you said, quite a few ancient, medieval painters who have talked about neural tube defect. But there is a chap from Vancouver, he's a medic, he's a A&E consultant who does excellent paintings on encephalocele and meningomyelocele. I would strongly advise to just check on the internet. He's, for presentations, I use it routinely, and they're fantastic diagram. His name escapes me at the moment, but I'll definitely pass it on to you guys. If you want to use presentations in modern slides and modern paintings on encephaloceles and meningomyelocele, open neural tube defect, There isn't a better source than, it's an open source. You can get it in the internet.
Okay.
Thank you.
Dr. Venkatramana, the last remarks.
I think Indian Society of Pediatric Neurosurgery should take up this mission to spread this message across to particularly to the rural areas. I think each one of us can take the responsibility of our own states and see that we can accomplish in the next few years. I think I'm sure we have done this iodine supplementation over the years. Every government has now, it's become mandatory now across the country. I think folic acid is still not mandatory, but it's certainly many governments have adopted this in the country. And I think we need to educate and create a lot more awareness among the prospective couples as well as the obstetricians so that we can spread this message across.
Thank you, sir. And lastly, over to Professor Chatterjee for your last remarks, advice to residents, juniors about the importance of embryology.
I think I've made plenty of last remarks. I'll just tell Venkat that as president, that has been one of my ambitions, that during my tenure, we can actually get to the government and try and see if we can get this folic acid implemented. Unfortunately, the pandemic has put all this onto the back seat a little bit, but we hope to take it up very soon.
Sure.
Thank you all. With this, we come to the end of this webinar of today. Our next webinar will be on 5th of August. After we skip to one Thursday and go to the next. And that will be on the basics of neurosurgery, basics of control of micturition and what can go wrong. That is a very important topic, both from the exam point of view and from the routine practice point of view. And the speaker will be Dr. Tapos Banerjee, one of the most eminent neurologists of Kolkata. So thank you and see you then. And over to Deepak for the closure.
You have muted. You please unmute yourself.
Deepak, are you on?
Yeah. So viewers, thank you very much for joining us. 154 neuroscientists joined us today. That is a very strong number to listen to Professor Sandeep Chatterjee's basics in embryology, which he explained step by step and made very relevant points. And I think the best take home came from Dr. Venkatramana, that folic acid should be a wedding gift to the newly wedded lady. So with this, I have great pleasure and privilege to thank Professor Sandeep Chatterjee, our speaker, Dr. Ajay Sinha, our panelist, and Dr. Venkatramana. Thank you for coming into this webinar and giving your valuable suggestions and advice. Thank you very much, Dr. Kaushik Seal, for coordinating this session. This is Deepak Naik on behalf of Health and You, signing off and requesting you to join us for the next episode 3 of this webinar series, Basics in Neurosciences. Thank you very much. Good night.
Bye.
Good night. Thank you all.
Good night. Good night, everyone. Thank you so much.
Bye,
Nice
Jay.
catching up.
Bye,
Bye. Nice, Venkat. Nice catching up with you guys on. It's all virtual these days, isn't it? Stay safe, guys. Thank you so much. Bye. I better go and see my patient. I haven't said hello to her. Thank you. Bye.
Thank you so much.
Bye.
Thanks, Kaushik.
Bye, Kaushik. Bye, Sandeep.